Hello and welcome to the Cytokine Signalling Forum Author Interview Podcast. I'm Professor Peter Nash from the University of Queensland, and today I'm talking to Professor Paul Emery, leads Musculoskeletal Biomedical Research Unit from the University of Leeds in the United Kingdom. Welcome, Paul. Thank you very much for your time. Today we're talking about this recent publication, Efficacy of Monotherapy with Biologics and JAK Inhibitors for the Treatment of Rheumatoid Arthritis, which went online 20th of August this year in Advances in Therapy. So, Paul, can you just give us a little bit of the background to why you did this particular publication?
The background to this, Peter, is that the recommendations of nearly all groups is that biologic and the newer oral agents should be used with traditional disease-modifying anti-rheumatic drugs. Yet in practice, it's estimated that it's barely a third that actually, well, it's actually two-thirds who actually take it correctly and a third who do not. But that's an underestimate, as we know, by prescription sheets and so on. So a large number of people are not taking the combination of a conventional synthetic DMARD with a biologic or one of the new targeted synthetic DMARDs. So what we wanted to look was at the objective evidence for what happens when you use particularly biologic DMARDs on their own. And it was a systematic review of the data up until 2017, sorry. And there has been some further data after that, particularly on the JAK inhibitors, which are the targeted synthetic DMARDs. But it's a complete review of really what's been done in terms of randomized controlled trials.
Thank you. It's certainly very comprehensive. Tell us what method you used to put this paper together.
Thank you, Peter. The methods we used were to use Medline, Embase, and the Cochrane Central Trials Register. Also, the conference proceedings from the ACR and EULAR we used to select randomized controlled trials.
It's a shame, isn't it, that oral strategy and RA Beam came out after your deadline. So maybe
yes, and
data done.
Yes, it was a pity that a lot of data from the new oral agents came out afterwards. I think, however, that there are some sort of general conclusions one can make, that the most dependent on having conventional synthetic DMARDs are the TNF inhibitors, and one becomes slightly less dependent with the IL-6 inhibitors. The IL-6 receptor blocker, tocilizumab, didn't show inferiority as monotherapy compared to the combination. And as you know, there are these more later data which suggest that the oral JAK inhibitors may well get relatively smaller benefit from the addition of a conventional synthetic DMARD. The logic behind all of this is that methotrexate does a variety of things. It actually increases the bioavailability of certain drugs, particularly adalimumab and infliximab. It has a action which is separate to the biologic DMARDs, so it may be a certain amount of synergy. And there is also the fact that you have an ability with methotrexate to inhibit the development of antibodies against the drug, the anti-drug antibodies, which may be helpful in nearly all the cases. Of course, the last named is not going to be influenced with JAK inhibitors because they won't have significant autoantibodies, and the other two may be less. Therefore, you're correct in saying it is a shame that those weren't, the full data were not available.
Right, and how are they going in the UK? They've certainly been taken up very widely in Germany, for example. What's the UK scene like?
Well, there was, until the NICE pronouncement, there wasn't reimbursement, there was only special access, and that was mainly for tofacitinib. Now we have the ability in the UK to get reimbursement for methotrexate failures onwards, the uptake has been actually quite rapid. I don't think it's quite as rapid as it has been in certain countries in Europe, where it's been one of the fastest launches ever for certainly for the Lilly product.
Yep. And do you think that guidelines for RA, should they be altered?
I think the guidelines are correct in saying that it's better to start, if one can, with biologic DMARDs combined with conventional synthetic DMARDs. They do say that if there's contraindications, and one contraindication, of course, is that certain of the combinations have an increased risk of infection. And therefore, in some patients who are particularly prone to infection, and we know which ones these are, it would be reasonable on a cost-benefit analysis to actually treat with monotherapy. And I think one would be moving away from TNF inhibitors if that were the case, because they are less effective. There are, however, data of patients who start on combination and then stop the conventional synthetic DMARD. In COMET, there was a second year where the methotrexate was stopped, and the relative maintenance of therapy there suggests that perhaps the anti-drug antibody effect is particularly important in the first months and years of the disease.
Can you comment on whether your findings apply to early disease or late disease? Both?
The conclusion in the paper is that this applies to all stages of the sort of continuum of RA. I would say there are slight differences for individual drugs, but as a general conclusion, that holds.
And with some of the newer agents, it's hard to see a role for some of them. Where do you see the new IL-6 inhibitors fitting in, given the monotherapy space? Well,
the JAK inhibitors are very effective and are more effective than methotrexate. The benefit of methotrexate with the JAK inhibitors is limited because of the additional side effects that the two have when given together. One could make the case, if one's failed methotrexate, that perhaps one would start with the combination, and if the response is good enough, one could withdraw it. Or alternatively, in someone who's had side effects, one could start with the monotherapy with the JAK inhibitor, and if there was insufficient efficacy, then add in the methotrexate. So I think there will be particular ways of managing patients with the new data that are available now.
What about sarilumab and sirukumab?
Well, I think they will probably follow the same sort of pattern. As I said, the IL-6 inhibitors are less dependent on a conventional synthetic DMARD, although the overview of the tocilizumab program concluded that methotrexate and tocilizumab was the optimal combination. But again, if side effects or infections are the major issue, then I think one would be pretty happy to start with monotherapy.
And you've got a few head-to-heads. Do they have issues? Are they disappointing because they leave methotrexate out?
Yes, that is an issue, but because some of the monotherapies that have done head-to-head have included methotrexate elsewhere, I think one can be fairly confident about where they stand in the hierarchy of response early on. Of course, most people have used adalimumab as monotherapy to compare with, which, as I said, is a bit more dependent on the addition of a conventional synthetic DMARD.
Is there a hierarchy amongst the TNFs of MTX dependence?
Well, I think infliximab is the most, because of it being a chimeric antibody, and that actually exaggerates the impact of anti-drug antibodies if methotrexate isn't added. And we know from the very early studies that infliximab that there was a tachyphylaxis very early on without methotrexate. So I think infliximab is definitely different, and probably Enbrel is the least because it has fewer anti-drug antibodies. But between that, and you could hope that certolizumab might be slightly bit different, but in fact the data don't really show that sufficiently well to make a firm conclusion.
Having done all this work, is there a research agenda you would like to see?
I think there are small areas that need clarification. One of the issues is the benefit one gets from the addition of methotrexate as a conventional synthetic DMARD worth the side effects in the modern era where erosions, for example, are very rare? Perhaps another question is, what role do they have in preserving cartilage, which would be perhaps more relevant these days than erosions? But I think we have a lot of data now, and much more important is the individual tolerance of a drug, which at the moment is very difficult to predict. So the question is whether we should now move on to other disease areas such as psoriatic arthritis and ankylosing spondylitis, where there are, again, the use of biologic DMARDs, and where conventional synthetic DMARDs aren't conventionally used, but there are actually some data that suggests perhaps in circumstances they should, such as the continuation data. And I think if we were going to move on, there are a few things. There are limitations to the study, which we note in the paper, which is that we did look at all data, which may not be fair, as Japanese patients are different in terms of their tolerance of conventional synthetic DMARDs. We didn't actually rank the quality of the studies, which perhaps we should. And I think probably the largest defect in the study is we don't look at the long-term data, which has been shown to be important in these other diseases, particularly for maintenance on therapy with conventional synthetic DMARDs. So I think there is a role for continuing this in other areas, learning from what we did not perfectly in this study.
So thank you very much. Finally, any take-home messages from all this hard work that you've done? Use the combo as a reason not to. What kind of take-home message do you have?
I think the take-home message is that the ideal remains the combination of conventional synthetic and a biologic. The message, which doesn't come from the paper, but I think we're learning, is that's less important for the targeted synthetic drugs. We may not need to give it forever for most of these drugs. Probably the early phase is the most important, and that if you have to do without it, there is a list and an order with which you're most likely to get efficacy without the conventional synthetic DMARDs.
Thank you very much for your time, Professor Emery. If you'd like to know more about this paper and others uploaded to the CSF website this month, detailed slide sets are available in the publication section at cytokinesignaling.com.